Hi everyone, and welcome to Reverse Rett's Bitesize. I'm Catherine Sim, Operations Manager at Reverse Rett, and mum to Georgina, who's 29 and has Rett syndrome. At Reverse Rett, we believe knowledge is power. As parents of children with rare diseases, we know it's often up to us to become the experts so that we can make sure our loved ones get the care and protection they need. These bite-sized sessions are here to help with that, to give you up-to-date information and access to experts who can help fill in the gaps, so you feel more confident and empowered to advocate for the person you care for. Just a quick reminder, these sessions are educational, not medical advice, but we do hope that what you learn here today helps you ask the right questions and get better answers. We try to keep these things truly bite-sized, starting and finishing on time while getting through as many of your questions as possible. We are recording today's session, so please don't make or share any of your own recordings. We will email it to you after today's session. Do stay on mute throughout. It's just to give us the best quality and keep everything as clear as possible. We have started with the cameras on for security reasons, but don't worry. We know many of you are listening while caring or working. Once we've checked everyone in, you can turn your cameras off. Okay, so now more people have been joining, just as I've been saying all of that. So hello to everybody and welcome to our session today. I'm going to hand over to Rachel now and she's going to take it from here.
Thanks, Catherine. Hi, everyone, and welcome again to today's Reverse Rett Bite-Size session. We're really glad that you've joined us. So if you're a parent or carer here today or listening and watching afterwards, we know that you're someone that's deeply invested in doing the best you can for the person you care for. And we know as well that you're already an expert on your own child. And hopefully by the end of today's session, you'll have a few extra tools and resources to strengthen your ability to advocate for that person so that they can lead a healthier life as possible. So today we are talking about the Reverse Rett Health Milestones project. Now, often when people hear about this kind of thing, it puts them off. The instinctive reaction is, oh, data collection, boring. How does completing a survey actually help my child now? And honestly, I used to feel exactly the same when my own daughter, Amber, who is now 30, was younger. I hated the term natural history study because I felt I didn't need to learn about the natural history of Rett syndrome when I was watching it unfold in my own home. But today we want to show you how the health milestones work we've been doing is being used right now, not in a distant research project, but things that are already helping families and hopefully helping to improve care as well. So how did the project begin? All right, we're one slide behind. At Reverse Rett, so we run the patient registry for the UK, which is called the Rett Registry UK. And this allows us to track how many people in the UK have Rett syndrome, where they are, the age they are, and other key information that helps prepare not only for clinical trials, but also for delivery of treatments once they're approved. And unlike many registries that gather information once and let it sit static, ours is very warm and alive. And we do accuracy checks. Go back to the previous slide, please. We do accuracy checks year round on the registry. So Evelina, who is our registry coordinator, actually contacts, you might have experienced this, she'll contact people directly and just check that your phone number is up to date, your address is up to date, and anything else that we need to know. So through that work in the last couple of years, we did notice that there's been an increase in mortality in the last 5 years, particularly among teenagers, and we needed to understand why. And this is important because for our organization, which is very focused on treatments and access to treatments, everything that we learn through the registry connects to the bigger picture, in particular, access to new treatments. Because bringing about treatments for Rett syndrome isn't just about science and research and clinical trials, it's also about what comes after that, which is approval and funding. And to get funding in for the NHS, as probably everybody here already knows, because these things are in the newspapers all the time, we have to show three things. One, the burden of the condition. Nobody likes that word burden because we all adore our children and we don't think of them as a burden, but that's the term that's used in the situation. The burden of the condition, the unmet need, so the fact that there aren't any already approved treatments and how badly we need them. And then also the impact that new treatments could make. So going from a situation where you're untreated to a situation where you're treated, what's the difference there? And as everybody hopefully already knows, we have a couple of gene therapies in clinical trials right now for Rett syndrome. As those progress and we move towards a situation where potentially those treatments will go towards the regulators and payers for approval, we have to be ready with the UK specific information to support health technology assessments. And those are the assessments that NICE and the Scottish Medicines Consortium do to recommend or not recommend a certain treatment for approval for funding by the NHS. So as part of our work to prepare that information, we started working with a company called Costello Medical, and they're specialists in health economics. And the idea was to get them to help us build a cost of illness model for Rett syndrome in the UK. In other words, what it costs, not only the NHS, but our overall system, NHS education, social services, and so on, to pay for somebody with Rett syndrome of their lifetime. And again, I apologize. I'm a parent myself, and I've always found it deeply offensive to hear people talk about my child in terms of what the cost is. But this is the reality of assessing treatments for funding by a publicly funded health service. And so also you might think to yourselves, well, these pharmaceutical companies that are trying to get the treatments through, they've, got more money, and they perhaps it's their responsibility to look at collecting this kind of information. But I can tell you that most of the companies that are dealing with these new treatments for Rett syndrome are potentially US based, or they're relying a lot on US data. And some of you might be aware as well that in the last several years at Reverse Rett, we've supported burden of illness studies that the pharmaceutical companies have done too. And those have been useful, but they don't pin down necessarily the geographical disparities. Okay, so the general consensus is Rett syndrome is Rett syndrome wherever you are. And that's true, but there are some caveats there, which I'll explain. So if there are, as we think there are, based on anecdotal evidence, geographical disparities, UK outcomes can be poorer due to more fragmented care and fewer interventions. And because the data that companies draw from to build these resource kits for taking to payers are not breaking down the differences in outcomes in different countries, that means that some of the information we need is missing, and that's what we're trying to change. Okay, and I should explain that the reason that's important is because when you do have a publicly funded health system, you need as much evidence as you can that the disease is as difficult as possible, and that the jump in the improvement from the baseline is properly represented. So we're not trying to make it look worse, but indeed, if it is worse, that needs to be properly represented, because especially in the UK, the value for money that you need to demonstrate in terms of what the treatment can do for somebody is competing with other disease groups. So to look at UK outcomes, the first thing that we needed to look at was the very worst, most difficult outcome, which is obviously when people die. And that's why we started the mortality survey. Now, it's important to say at this point that about life expectancy in Rett syndrome. So when my own daughter was diagnosed, which was in the year 2000, she was just before she was 5, we were told that day basically that she probably wouldn't make it to 20 years old. Now we know that people with Rett syndrome can live into their 50s with adequate healthcare. And this information comes from a paper that came out in 2015 called The Changing Face of Survival in Rett Syndrome, which is cited here. If you just Google that, you'll be able to read the whole paper, or if you let us know, we can send it to you. But there's a caveat here which isn't really discussed, and that is, well, what's adequate? What does adequate mean? And in the paper, adequate isn't actually defined. So you have to look at what the conditions were of the people that they've considered in the paper. So in the data in that paper comes from the US Natural History Study, which is a longitudinal study that was done, over a long period of time. And the N number for that, for those of you who don't know, it means the number of people that's included. It literally stands for N, I think, was 1,189, but they are all US patients. And because they're US patients, what's adequate there, what's considered standard, isn't necessarily the same here. So if we zoom out, don't read this slide for a minute. Let me explain this. Try and imagine in a setting, say in a country where there's low resource, say a war-torn country, a rural community, even in a tribe or something like that. How long do you think somebody with Rett syndrome would survive? Okay, so for me, I know my daughter's always been quite a healthy person for Rett syndrome until the last few years, but when she was a child, she developed seizures when she was about 6. She also needed a feeding tube. So without some of those things, so if we'd been a family that was living in a tribe in Brazil, she probably wouldn't have survived past 10 because she didn't have those things. And so if you think about it, a lot of time in those kinds of situations, basic needs for people like nutrition, seizure control, safe feeding, or orthopedic surgeries, which are often needed in Rett syndrome, just that those things don't happen. And then at the other end of the spectrum, you have countries with high levels of intervention. And while from the outside, countries like the UK and the US look fairly similar, we speak the same languages, people have similar kinds of wheelchairs, maybe. People talk about having therapies. So it looks similar, but actually what people receive and what they have access to can be quite different. And here on this slide, I'm not going to go into it in great detail, but we can send it out afterwards. You can see some of the key issues broken down. And to summarize it, the US model, which is obviously an insurance model where people are paying, or their insurance companies are paying for treatments, that rewards activity, whereas the UK rewards efficiency. As everybody knows, GPs have X amount of time to spend with you. They don't. A lot of consultants are trying to discharge you. They're not necessarily incentivized for taking you off a list, but the model is to get things sorted out as quickly as possible and get you out. Whereas in America, it, per visit, the doctor makes money and the company makes money. That's the hospital and so on. So rare disease families, and this isn't just limited to Rett syndrome. That's why I'm saying rare disease families, because these issues are common across the board in rare diseases. They need intensity and continuity to manage the conditions. And our NHS is just not structured that way. And particularly with the pressures that it's been over the last, there's been a few different factors, but the last 5 to 10 years, that has had an impact on what was already a stretched situation in terms of patients having access to the continuity they need and the care that they need. Okay, so that's why we need UK specific evidence to demonstrate true burden and unmet need, because again, pressures on the government, on the NHS as such, that we've got to make the best case possible to get emerging treatments through. So when Costello Medical, they do a very detailed audit of all the information that's out there. And we told them up front, obviously, we know there's a problem where there's gaps in the information that's out there and the geographical disparities aren't factored in. They also found these gaps in UK health outcome information, and so we then designed this mortality survey, and we made it as simple as possible. We made it hopefully respectful. Actually, I know we made it respectful because what we did was we worked with a small group of parents whose children had died, to get their feedback on the way everything was worded and how long the survey was and so on, to try and make the whole thing minimally burdensome for families who've already been through so much. And I just want to take a moment to stop and acknowledge all those families that took part, because none of this work, which I think has turned out to be very useful, would have happened without their willingness to share their deeply painful experience to help other people. So when we started the work, we hoped what we'd learned from the survey would add to our toolkit for the UK health technology assessments, as I've explained, but we also thought, well, hopefully this can help contribute to our understanding of how improvements in care pathways could lead to better health outcomes. Now, one of the challenges in looking at this kind of thing is that Rett syndrome presents really differently for everyone. So while, a lot of time we'll hear people say, no one person with Rett syndrome is the same. There are some things that are pretty standard. So, most people with Rett syndrome don't speak. Most have trouble using their hands. Half of them don't walk. And then the other half that are left are likely to lose their mobility. But in terms of the other symptoms, especially the secondary symptoms, there's a lot of variability. In some diseases, you have quite a predictable pathway where a specific problem will happen at a certain time after a certain number of years in every person. And that doesn't happen in Rett syndrome. Things appear at different times, a bit like whack-a-mole, I always say, where the different symptoms are popping up at different times for different people, but also at different levels of severity, which means because there are so many symptoms affecting lots of different people in lots of different ways, at lots of different times, they're very difficult to measure and compare and look at what's causing people these poor health outcomes in particular. So what we decided to do was strip back the noise and focus only on the key turning points for people and ask them really just yes or no questions about specific interventions, whether their children have had specific interventions, or about clear symptoms like scoliosis surgery, rather than asking them about symptoms that were more variable, okay? So, for example, we wouldn't say to them, how's your child's breathing? Because this question about how's your child's breathing, we know that most people with Rett syndrome have some kind of breathing irregularity, but they're all different. So it's really difficult to say, well, because this person had a breathing irregularity and now they've died. Do you see what I mean? That's a simple example, but it's trying to show you that we took out those things that added more complexity to it. And once we did, patterns begun to show. So this is one example. We're not going to go through all the examples right now, but this is one example. So through the mortality survey, among people who didn't have scoliosis surgery, or perhaps couldn't have scoliosis surgery because perhaps they were deemed ineligible or it hadn't been identified yet as being an issue, we saw common risk factors. One of those risk factors is bone density issues, okay? So just to explain it properly, if somebody has bone density issues, and they need scoliosis surgery, they'll go on a waiting list for scoliosis surgery. And then perhaps when they get to that point of they're ready to have the scoliosis surgery, a bone density check is done. And the bone density check shows they do have a bone density issue. So the surgeons don't want to proceed until the person has treatment for bone density issues. And that all takes so long with different waiting lists and things that by the time the person has the treatment, their scoliosis has become too severe to safely do the surgery, which is usually because of respiratory issues that come about as the person's curve gets worse. And then because they can't have the surgery, they go to end of life care. Okay, so, or sticking to pathway one, they can have the surgery, but it's so risky that then they're really poorly when they haven't, when they're recovering from the surgery, and often they can't come off the ventilator, and then they die. Okay, and then in pathway two, they say they need the surgery, they have the surgery, but nobody had identified there was a bone density issue because it isn't standard that somebody checks that. It's down to your local area, whoever's doing the operation. Then they have the surgery, and after some time, because the bones are soft, the metalwork breaks down. Perhaps it breaks the skin, the person then gets an infection, and then they go to end of life care. Okay, so this just shows you the kind of pattern that we've found in through looking at the mortality survey, and we have a number of these examples that we're intending to disseminate so that people can learn from these outcomes. Okay, and now Catherine is going to talk about how we immediately responded to what we were learning from the mortality survey.
Thank you, Rachel. The first thing that we looked at was, oh my goodness, most doctors, we don't know all of this, and we are the experts. So how do we expect our doctors in the hospitals, that may be a rural hospital, where you may be the only person with Rett syndrome? So Rachel decided to look at it on a different angle and started building the alert card. So we've sent that out to, I think, pretty much everybody on the registry now. And hopefully you've all got one and you found it useful. I am going to be doing another little survey shortly just to actually look at that, so don't be surprised if you hear from me again. We wanted to give you a piece of equipment that is easy to hand, keep it in your handbag, but what it does, it means you don't have to keep explaining to every expert that you come in touch with in an emergency situation what Rett syndrome is, what the different key factors are, and what they need to be aware of. So that's why we sent these across to people that we became aware of would benefit from it. So I hope you have benefited from it. Sorry, my computer hates me today.
Then what we decided to do as well was to check living patients for the same issues as we'd asked about on the mortality survey. And we decided that the best thing to do would be to ask the same questions before people have had this hardest outcome. So where further back in the disease trajectory could intervention take place that could help mitigate poor disease outcomes? And so what we would do is we would ask the living patients' families these questions, and then where these issues popped up, we would send an advocacy letter where the red flags appeared. So as you can see for the help through this slide here, we started with the oldest group, which is the patients that are over 25. And we picked those really, one, because they get left to the end of everything. Catherine and I both have daughters who are over 25. And obviously, people who've made it to over 25, they have within them some answers to some of these questions about longevity and mortality. Although obviously they got to that age before some of the things that are compounding issues within the NHS happened. But we thought it was important to go to them first. And we made the survey as easy as possible, same as the mortality survey. So you can see here the average time to complete the survey is 11 minutes. We saw that there were a lot of patients who weren't having the checks and the referrals they needed. So there were even people in that over 25 group whose child had never had an ECG. So people with Rett syndrome should be having an ECG at baseline, and then that's as soon as they're diagnosed, and then every year after that, to make sure that they don't have long QT syndrome, which is treatable condition, common in Rett syndrome, and more common than it is in the general population, and actually something that's potentially fatal if it isn't looked after properly. So something like that can immediately be addressed. We decided that what we needed to do is, once we had all this information, we had 54 responses in the first instance. That's a lot of people to write back to. So we decided the most efficient way to deal with this, from our perspective as quite a small organization where everyone's doing multiple jobs already, try and just pull everyone that needs a particular kind of referral at once, and in bulk send them all a pro forma letter to request an appropriate referral. So if it's that somebody needs an ECG, we pull all the ECG people and we write to them all at once and say, here's your ECG letter. This might mean that some people would get a few emails from us with different subject lines with a different pro forma letter on because they had multiple issues, okay? But what we found was that didn't really work. Go rewind a slide, please, Catherine. You're a bit slide happy today. So what I'm going to do is I'm gonna tell you when to move the slide over. Okay, so we decided that the greatest risk to people was when there are combination factors, okay? Just from what we'd learned in the mortality survey. It wasn't necessarily individual symptoms or a lack of specific intervention that was the issue. It was when there was a few different symptoms or a couple of different areas of non-intervention. And of course, with Rett syndrome, that varied from patient to patient. Okay, so this is a good example here. If you can zoom in, I don't know if you can zoom in.
No.
This is a good example of a combination factor. So what we've done here is this is where the data has been pulled together, so all the patients together, and these are their people's answers. So the first box was asking them, before this first box, we'd asked them, has the person had scoliosis surgery, yes or no? And then we said to them, if no, are they awaiting a date for surgery? Have they been deemed ineligible for surgery, or has surgery not yet been considered? Say they've got quite a easy curve at this point. Okay, so we have the answer to that. We know that these all these people who've been deemed ineligible, or people whose bear in mind that this is the data from the older age group, okay, so over 25. So most of them that needed surgery would have had it by now, yeah? Okay. Now, just thinking about these in terms of risk factors, though, if a person is awaiting a date for surgery, okay, and they have recurring respiratory infections, i.e., 3 a year, which is the question you can see in the box below, then that's a problem, okay? So we need to go because of what I was explaining to you earlier about the bone density, the same goes with respiratory infections. So if somebody needs to have scoliosis surgery, and you're playing this waiting game of when is the appropriate time in terms of their growth and age and hospital waiting lists for them to have the surgery, but they're already somebody that has a lot of respiratory infections, the chances are that if you wait too long to have that operation, the person will not be able to have it because the respiratory situation could deteriorate to a point that the anaesthetist isn't comfortable doing the surgery, or the curve has compromised the respiratory function to that degree as well. So we had to think of a different way of addressing this, because it's not enough. It doesn't emphasize to the family, and it doesn't emphasize to the professionals involved enough what the holistic issue is. And we know We know that most people with Rett syndrome in the UK, there's not one doctor looking after them. There's usually different doctors that all look after different body parts. And a lot of the time they look at those issues in isolation and don't consider the confounding factors that are involved as well. And so we had to draw that information off on an individual level. And so that's what we did. We decided that rather than sending people these separated letters that wouldn't convey the compounding of issues to either the parent so that they can do all the chasing that we all know about, or to the receiving clinicians, whether or not that's the gatekeepers that are stopping you getting to the right consultant or the consultant themselves. We need to make sure everyone understands. So, change slide. What we did next was we pulled the data on an individual level. So Catherine is absolutely amazing at Excel, and we had all this data coming in, and one day I was kind of looking at these individual responses and going, I had to turn my head like this for one, because of the way it was laid out. So I was looking at them all and the writing was all really small, and I said to it, it's really arduous, taking too long. I can't get through all the patients. Can you make it so that we can pull just the information that we need and I can glance at it and go, right, who's got a few of these factors, and how can we identify quickly and sort who needs to write to which families? So she made these beautiful boxes, which just had the answers to the questions in. And then we were able to look at them and go, okay, where they've said yes or no, and we know that this is a risk factor based on the other questions that they've answered. Okay, we highlight it and then we write them. Okay, and Catherine will speak in a minute to how we distributed the work there, but just so I can explain this one. So as you can see, this is the same kind of example. This person actually needs, the person's having the scoliosis surgery. They know they're going to need to have it. We don't know what stage they're up to, but it's been acknowledged. So one would imagine 40 to 50 degrees. They have respiratory issues, but they're under a specialist good. We don't need to address that. They haven't had a bone density check and they do want help. That's good. But sometimes people will say they don't want help, in which case we write to them and go, good that your child's having scoliosis surgery. Bone density can be an issue because of this. And so if you can, you need to ask for a bone density check, in which case we can give you a pro forma letter. And we've highlighted as well that the person's never walked. And this is important as well, because we know that one of the biggest risk factors to people in terms of mortality, the scoliosis issues, lots of these things, if the person has never walked, the risk factor is greater for them. So what that means is, although we don't need to go back to the parent and emphasize this, when we help them with the pro forma letter we put in, and the person has never walked, so their risk is higher. And sometimes we'll even put in, if they've given us their MECP2 mutation, and this is, veering off slightly complex, although the mutation doesn't necessarily correlate with disease severity, if it's what is known quite well as a more severe mutation, we can also say, and they have a more severe mutation, that it's usually associated with poorer outcomes, which all adds to validating why they need that referral and why they need it now. Okay, so now over to Catherine to explain how we worked out how our small team could deal with this, because obviously once we'd done the over 25 patients, we then moved on to other age groups.
And I do apologise that my mouse seems to be letting me down today. So as Rachel said, we started with the over 25. We had an amazing response, which was brilliant. We then said, well, hang on a minute, what about everybody else? Because all of these things impact all of our people with Rett syndrome at different ages. So we then did a new survey and split it out into ages again. So we did the 19 to 24s. and then we did the 11 to 18-year-olds. And what this is a Gantt chart. It's a new thing that I learned, as I do love Excel, quite sadly. And what this is doing is laying out the project as a whole. So for each person that we sent the initial survey to, we then had to cross-check that survey to see, cross-check that list to see whether they had responded, whether they'd completed it or not. We then sent out follow-up emails because we're all busy. Sometimes things don't end up in the right email boxes, and we wanted to check that it had been received. That then brought in another slew of completed surveys, which all had to then be analysed. So as Rachel says, head on the side and working out what's going on and really taking it down to an individual basis. Each person had their own tab with the little graph that we've just shown you previously. That then went to Rachel, who then cross-checked and triaged everything that was being done. And then we then started sending out the referral letters. So as we started looking at this for the over 25s, we were like, well, hang on a minute, that's actually a massive, massive job. So the decision was taken to bring Izzy in on the project with Martha. And so we then started looking at, right, if we're going to do this, what time frame, I will get Izzy to give you a little wave in a minute. What time frame are we looking at for all of this? Because it needs to be concise. We need to have all of this information together in a timely fashion. So each colour graph basically speaks to each age category. So we're now in October, and I'm delighted to say that the majority of this work has now been completed. We do still have people that we've written to that we haven't heard from. So if you have had a letter but you haven't filled in the survey, I would ask you to contact me afterwards and I'll resend it to you, because every piece of entry is so preciously needed. The other job that then came off the back of this was that we recognised that we have a lot of people on the registry where we just don't know what their mutation is. And it may be that they don't know what it is, depending on the age of their child. So the next project arm of this was for Izzy and Martha to contact the people and say, do you know what your mutation is? Some people do, but they don't know what it means. Some people have never had a specific mutation. So we did a couple of template letters that we sent to those people and said, send this to your GP. They will have the information on file. If not, go to your neurologist, your consultant, whoever may be in charge. And then for those who think that they've never had a test, they've just had a clinical diagnosis, then we've done template letters for them to have a full genetic screening. So all of those things all take time. And as Rachel said, we're a very small but powerful team, but we did need some extra help for that. And back to Rachel now.
So just before we move on, we should say as well that we did not yet do under 11s, okay?
No.
And then the reason for that is because this is an iterative process and we are learning as we go along. And so what we realized after we did the over 25s is when we went to the next group down, we decided to go to what we're viewing as the high risk group, which was 11 to 18. We then realized, okay, the first thing I did is I handed it to somebody else to do, because I thought, well, we've done this once and we know what we're looking for. And they came back and they said, oh, there's not really many red flags here. And then we kind of came to the realization that, of course, there's not, because people are younger and the problems are just emerging. So we have to make the bar lower for what we consider a red flag. Okay, so every time we go down an age group, we have to do that again. We have to sort of learn from what we've learned previously. And we haven't yet quite worked out what we're going to do with the younger patients. But I'll also speak to what families can do now as we go to the next slide. So what we're planning to do with the information that we've gained from the mortality survey and the health milestone survey is publish the information properly so that clinicians can use it as a foundation for Rett syndrome care pathways, because it's really quite an innovative way of looking at it. The literature is full of information about the symptoms of Rett syndrome, and there are some guidelines, and there are lots of handbooks of information with every symptom listed, but it's very overwhelming, not only for the family, but also for the doctors. I mean, when we had our LEAP conference last year, the doctors even said, because there's so many symptoms, it's helpful if families come into us and tell us what their priorities are for the appointment. We only have a certain amount of time. What do you want to deal with? And what we're saying is there's these key factors that in all patients should be being monitored holistically, and where they are happening, this is where intervention needs to take place, i.e. a referral to the correct kind of clinical service that can monitor or take action. Okay, so we're trying to move towards publication. We're also going to, at the moment, the registry, the survey is not built into the registry. It's something that people register and then we send it out to them separately. So we have to get it built into the registry because we want to repeat it annually. And also we would like it to be more automated so that when people register, it's automatically there and that people can go in and update it and see what they've already said. And then we also want to develop resources for clinicians as well, so that when we're sending out these pro forma letters and we're saying, you know, if this person's having repeated chest infections and or if they have sleep apnea, which we know affects a high percentage of people with Rett syndrome, they should be going to get monitored for sleep apnea. Okay, and sleep apnea isn't just about, you know, someone has disrupted sleep, although we can argue that that's worthy in of itself. It also is a respiratory issue. It puts pressure on the heart and stuff like that. So that can be a contributing factor to early mortality. It's trying to make sure that we put in the resources. This is why these things are important for families, because nobody really pins those things down for us. And it's also about saying to the receiving clinicians who, you know, say, for example, for respiratory, a lot of respiratory doctors in the UK have never seen someone with Rett syndrome. This is what happened to me when I took my daughter in. I've never heard of Rett syndrome. You give me a quick summary of what Rett syndrome is, and you know, this is a high level respiratory consultant in a big hospital. So we're putting together resources to explain not only to families, but also to the receiving doctors, this is the information that you need. Treat a person with Rett syndrome like a person with this other condition. And these are the things to check and monitor and you know, provide intervention as appropriate. We've already updated the website with new respiratory guidance, and as we've started to update with this new information, we're also reorganizing the website into a long-term information hub where we can put more of this specific information. That Wesley's currently working on that, and hopefully that will be available in the coming weeks. In the meantime, we will link to the respiratory guidance that's already up, although it's not pretty, it is there in the YouTube notes. So moving to the next slide, for families, what you can do now, you don't need to wait for us to publish that information. If you're not registered, register now by scanning this QR code, and someone will send you the survey, as well as emergency alert card. If you're registered but you haven't received it and your person is over 11 years old, let us know and we'll find out why that hasn't come to you and send it to you. And if your child is under 11 and we haven't sent it out to you yet, know that we are going to be moving into this age group. Here's what we think you need to focus on based on what we're learning and what's already in the literature. So number one, aspiration safety, minimizing the chest infections. We've got an aspiration fact sheet. It's just as important to think about things like how the person's positioned when they're eating. Is your child lying down drinking? Are they staying laid down, you know, for half an hour after they have a drink? So all those kinds of things are on the aspiration fact sheet and they can help you as well. If the person is having more than 3 chest infections a year, they should be having a respiratory referral, and we can help you with a letter for that. And if the person doesn't walk, okay, and it's clear that the likelihood is that they're going to have a scoliosis surgery at some point, and that is something that can often happen in patients that don't walk. They should be being monitored for the scoliosis. So if they don't have an orthopedic surgeon, not under an orthopedic surgeon, they should at least be under a neurologist who's looking at their back, or other doctor that's looking at their back on a regular basis annually. They should also get a bone density check and either have the vitamin D levels or have a supplement. And all of this is stuff that, you know, it's not new information, but these are the things that we're highlighting to you today. So the evidence for those things is already exists in the literature in different guidelines that's already come out. So if you need us to write you a letter for any of this stuff, for, you know, for someone to check your child's swallow, or for the respiratory referral, or for bone density checks, we can embed all of that information into the letter for you, and you can just send it out to whoever needs to receive it. Okay. Oh, and there's my what to focus on slide. So if you didn't catch those things, there they are. And there's Molly looking beautiful, standing in the stander. So there's obviously also all kinds of things, you know, that you can do to support children with Rett syndrome and adults with Rett syndrome and young people with all these different things. But what we're trying to do is distill the really key things and provide you with that information so that you have some clarity about what could be focused on if your child's in this situation, or if your child's in this situation, what are the key things that you can focus on. And so on the next slide here, we have a link to the Rett Registry UK app. And I think now we're going to turn over for any questions. I know we've bombarded you with a lot of information. We'll keep obviously sharing the updates as the work progresses. Yeah, but happy to take questions.
We've not had any questions in the chat yet.
No questions? Okay, that means we've maybe hopefully shared things in an understandable way. Is that true? Yeah, okay, thank you. I'm seeing a nod here.
I'm seeing nods, yeah.
Can we turn off the slide so I can see multiple faces? We didn't get any questions before?
No.
Is there anything that wasn't clear that people would like us to expand on?
If anyone does have a question, just unmute yourself now if you want.
Okay. Well, we've made good time then. We have kept the session bite-sized, which is a good thing.
Sorry, I've got
Sarah has a question.
Great.
I'm just interested in where the idea for the registry came from in the first place.
So, okay, so in about 2013, I went to a workshop, which was a rare disease workshop put on by an organization which was called at the time Find a Cure, which is now called Beacon. And what they do is they support rare disease patient groups that are emerging, because rare disease patient groups are at all different levels. A lot of them are founded by people like us who are just parents of children with different conditions. And then some of them become big organizations and others are quite small. And so they try and work with organizations at all levels to help nurture them into growing so that they can, you know, have a greater impact on their mission. And I was listening to a talk by a really amazing woman who's now died, called Christine Lavery, who had founded the mucopolysaccharide disease charity, MPS charity, and that charity is really a big organization now. And anyway, they had started a registry back in the day, and she was basically talking about the importance of a registry. And now this was before we really had any treatments coming into clinical trials. And she was basically saying, as a disease group, the power should stay in your own community. So don't sell your community's data, make sure you hold it and you use it for the good of the community. But you can just begin your own registry. You don't, because a lot of the time people were saying to us, well, we'd like a registry, but it's going to cost, 50,000 or 100,000. Researchers and so on. And then what would normally happen is the researcher would own the registry and our families would put info into it, and then we'd never have any access to it. So imagine if a separate, say, academic institution was gathering this information, nobody probably would have gone, because it's not in their remit or in their heart probably, to go, well, how can we use this now to help people? Whereas we've been able to go, we're getting this information in, we want to use it in real time. This isn't about selling it back to the pharma companies or, allowing academics to access it to put into their papers, although that can happen. We also want to make it work for people in the here and now. So that had a massive impact on me, and I basically went away and started a spreadsheet and called it a registry. And it grew and grew and grew. But we did a really good job at Reverse Rett because we began it a long time ago. So it's actually at the moment the biggest registry that there is worldwide of Rett patients, apart from that NIH natural history database in the States, which is also changed form and is not the same beast anymore as it was. So I think it was a really positive thing to do, and it definitely laid the foundation for us to have UK clinical trials of new treatments, the potential treatments that were basically drugs that were trialed here, starting from 2017. And definitely as you move forward towards going through the regulators and payers, you need to be able to demonstrate, okay, that you have the patients that need the treatment, how many of them there are, that the number of them aligns with the disease incidence, what's predicted to be, where-ish they are, so that you can think about delivery of treatments, and what ages they are and things like that as well. And then moving forward as potential treatments that are more mutation specific, say, come into the clinical trials, it'll be important to know, well, how many patients with this mutation do we have, or of this type do we have? Yeah. Okay, I think we had another question, Wesley.
Yep, we do. It's from Kylie, and she says, you mentioned the MECP2 test results as a mutation type, but if your child has a deletion, is a deletion just classed as a deletion?
Yeah, it is for us. So as we've started to do more deep work on this, we have started to sort of subset the deletions a little bit. But on the face of it, on the registry, if you click the drop-down menu that says what mutation is it, it just says deletion. But as we've been doing this work, and because a lot of the time, one of the things we do is we ask people, okay, do you know your child's mutation? And they'll write back and say, I've got it on a piece of paper, but no idea what it means. So Izzy will then look at the mutation, is sat right next to me here. Izzy will look at the mutation and go, we know what the really common ones are, and we can go back to them and say, this scramble of information means you've got R3060 or R168X. These are the common ones. But where we don't necessarily understand it, then we have to interpret the results for people and go back to them and say, the shorthand name for yours is this. So as we've got the more and more of the deletion ones, we've been able to split them out a little bit too. But in general, and maybe we do a session on this at some point, they don't correlate with disease severity as much. It's just that in combination with those other factors, it adds to the weight of the argument, if it's a more severe mutation, to be able to say, oh, the person has a severe mutation.
Sorry, hi Rachel, it's Can you hear me?
Yeah, does that answer your question?
Yeah, no, it does. It's only because obviously with the mutation there are specific labels and names for mutations. Sorry, I'm in a really loud place. I can't focus. But with deletions, obviously my daughter has a deletion on a specific exon. So you have answered my question, because I just wondered if you were going to start trying to categorise the deletions into specific severities and stuff like that?
Yeah, so we have been doing that. One of the things we started to do, because we were getting more and more variability in the mutations, is to provide people with a little fact sheet. And I started really doing that for Izzy and Martha. But we've now started to develop a little kind of catalogue of them, haven't we? So at some point we might start putting them out. The problem is that there are many, many, many mutations, and deletions. So some people have got one that that's never been recorded. Okay, so you have to kind of go to at what point is this not helpful anymore? Because obviously with Rett syndrome being an X-linked disorder, and then having the random X inactivation, so some people have a higher concentration of healthy MECP2 versus the broken MECP2 or the deleted MECP2. That means that affects the disease severity as well. So that's a confounding variable on top of what the mutation is. If everybody with the same mutation had the same X activation pattern, you'd be able to say this mutation means, you'd be able to say this mutation means somebody's going to be more severe and this group's not going to be as severe. But because you've always got that variability, it's really hard. So yeah, it's about going when does it stop being helpful and just adds to more paper for people to read.
Okay, thank you.
Yeah. Okay, if we've no more questions, Catherine, do you want to wrap up? Because we've...
Yes, thank you very much. Thank you all for your time today. I hope you found it as interesting as I did, and I've been working on it and I still found it really interesting. Just to remind you that this is not medical advice. It is just literally guidance to try and help you tread your way through the journey that is Rett syndrome. We will be sharing this video, so don't panic if you haven't been able to write everything down as well. Our next bite-sized session is going to be Wesley presenting, because he is very good at this sort of thing. We are all starting to now encounter AI in our lives, and certainly me, of a certain generation, it's not in our language. I do find it quite confusing and difficult to understand how to use it. So Wesley is going to be taking us through the world of AI and how we can use it to actually help us construct written arguments to help us get what we need for our children.
Yeah.
And that is already on Eventbrite. So if you haven't registered yet, pop on Eventbrite, have a look, and join us next month.
Perfect.
Okay, if that's it, thank you all for your time. Enjoy your Thursday. And
Thank you,
see soon.
everybody. Great to see you all. Thank you.